Thank you for joining us. We will get started at exactly 2:05. We're expecting quite a large group this afternoon, and we want to give everyone an opportunity to log in. If you have any comments, you can put them in the chat as we get started. We have about a minute to go, and then we'll get, well, I see we have about 56 participants already, so I think we'll be able to start, as I said, at 2:05. I think over these this will now be our third webinar together. We've made quite a few friends and associations between the various organizations that are participating in this. The Association of Black Women Physicians, First 5 LA, Black Infants and Families, Los Angeles, the Los Angeles County Health Agency, the March of Dimes, and PACLAC. So happy for this collaboration. So why don't we get started? Good afternoon, and welcome to Overcoming Disparities in African American Infant and Maternal Mortality, Part 3, Preterm Births. I'm Dr. Sylvia Swilley, co-chair of the Association of Black Women Physicians, ABWP's Advocacy Committee. Earlier this year, the Association of Black Women Physicians entered into a collaboration with the AIM Initiative to address the disparity in mortality for Black mothers and infants compared to whites. Our involvement in this effort goes beyond our professional participation. For you see, as mothers, mothers-to-be, grandmothers, godmothers, and aunties, we too are at risk to become victims. We join with AIM and the March of Dimes in addressing this critical issue. This is the third in a series of webinars dedicated to educating physicians, nurses, other providers, and the community at large about the disparate loss of Black women related to pregnancy and the death and morbidity of African American infants. The first webinar in the series lent focus and attention to implicit bias and racism as the primary drivers of these disparities. The second webinar addressed preeclampsia and shared local data, resources, and strategies to increase community and provider awareness. The personal experiences of mothers bring clarity to the subject and is a critical part of these discussions. Today, we turn to preterm birth. The agenda will include 2 presentations on the medical aspects of the problem, a personal story of a Black woman who experienced preterm birth, and finally, programs and system changes to prevent preterm birth and mitigate its impact on families. A Q&A will be conducted at the conclusion of all of the presentations. So put your questions in the Q&A, not the chat. Our first presenter is Dr. Kimberly Gregory. Dr. Gregory is the director of the Division of Maternal Fetal Medicine and vice chair of Women's Healthcare Quality and Performance Improvement in the Department of Obstetrics and Gynecology at Cedars-Sinai Medical Center. Dr. Gregory will discuss preterm birth, maternal considerations. Much of Dr. Claudia Alleen's job is dependent on the success of obstetricians like Dr. Gregory. After a career in private practice as a neonatologist, Dr. Alleen joined Southern California Permanente Medical Group, where she is a partner physician. Her experience includes stints on the Bioethics Committee and the Perinatal Safety Committee, and she has chaired the regional NICU committee at Kaiser Permanente Southern California region. Her presentation is entitled, A Brief Tour of the Complications of Prematurity. No academic presentation on preterm birth can bring into clear view the human toll. It is the story of mothers like Jessica Wade that compels doctors and other perinatal providers to do what they do. I will leave it to Ms. Wade to share her narrative and details about Mighty Little Giants, her nonprofit organization. Her perspective as a certified doula and lactation specialist brings yet another dimension to her presentation. Mashariki Kudumu is the March of Dimes Maternal and Child Health Director for Greater Los Angeles. She directs programs, provides community and provider education, and informs policies that improve the health of all moms and babies. Mashariki also represents the March of Dimes on local and statewide birth equity initiatives and is a member of the AIM County-wide Steering Committee. The work of the March of Dimes will surely inform how ABWP gets involved. And now we'll hear from Brandy Sims, Program Officer from First 5 LA, about the AIM initiative. Brandy?
Thank you, Dr. Swilly. So good afternoon, everyone, and thank you to the Association of Black Women Physicians, the March of Dimes, and PACLAC for being partners of the AIM initiative in this provider training series. I'll be sharing a brief introduction to the AIM initiative, and I encourage you to visit our website at blackinfantsandfamilies.org to learn more about us after this training. The AIM initiative was formed in response to the egregious disparities in Black infant and maternal mortality. Here in Los Angeles, Black babies are 2 to 3 times more likely to die before their first birthday than babies of other races, primarily from complications associated with preterm birth. You'll see Black babies in the gray line along the top, with babies of other races clustered near the bottom. Black mothers not only have to deal with the personal trauma of infant death, but they are also at greater risk themselves, dying 4 to 5 times the rate of mothers of other races, primarily from preeclampsia and eclampsia, which are complications related to hypertension. Previous efforts to explain and address these rates were focused on the behaviors and characteristics of the mother, such as whether she accessed prenatal care, ate her vegetables, and had financial resources. But research shows that these are not protective factors for Black women. For example, Black women who do not smoke have worse outcomes than white women who do, and Black women with graduate degrees have worse outcomes than white women who haven't graduated from high school. Research shows that the root causes of these disparities is racism. The chronic toxic stress of living in a racist society has a weathering impact on the body that results in poor birth outcomes. This slide shows the physiological impact of chronic toxic stress. Typically, if you're in a stressful situation, such as being chased by a dog, you have an initial cortisol release, but then the situation ends and the hormone release shuts off. But if you're a Black person in a racist society, having to deal with microaggressions at work or school, state-sanctioned police brutality, protecting your children from the school to prison pipeline, remnants from redlining that impact your economic potential, people insisting that racism does not exist, and other issues on a day-to-day basis, there is no stress hormone shutoff. This results in negative impacts on the body, and this slide does not address the very real impacts on mental health as well. All of this leads to poor health outcomes, including poor birth outcomes, such as hypertension, preterm birth, and infant and maternal death, and longer-term issues such as disparities in child development and kindergarten readiness. Then, when interacting with health systems, Black women often encounter implicit and explicit bias. These anecdotes are from the Listening to Mothers survey, where Black women reported negative experiences with providers. This can have life-threatening impacts, which is why an anti-racist approach is necessary when trying to improve birth outcomes. So we cannot overemphasize the importance of the leadership of the Department of Public Health through Dr. Ferrer in initiating the AIM effort and calling out racism as a root cause that needed to be addressed when thinking through solutions. This has created space for us and others in this effort to approach this work from an anti-racism and social determinants of health lens, and we've seen ripple effects nationwide. For example, since then, counties in Wisconsin and Pennsylvania have declared racism to be a public health crisis, and recently the Racism in Public Health Act of 2020 was introduced at the federal level. The Los Angeles County African American Infant and Maternal Mortality Prevention Initiative was launched in 2018 with the goal of reducing disparities in Black infant and maternal mortality by 30% in 5 years. In addition to the Department of Public Health and First by LA, our effort also includes other county agencies such as Department of Health Services, health plans, hospitals, universities, and philanthropy. But most importantly, it includes the community itself. So families that have experienced infant and maternal mortality and the Black-led community-based organizations that have been on the front lines of this work long before it was given the attention it deserved from the media, local government, and philanthropy. We've been deliberate about elevating their voices in alignment with the slogan, "Nothing about us without us," and research on public-private community partnerships that supports improvements in effectiveness and sustainability of efforts that are informed by the communities they impact. AIM is not a program or a project, it's a movement. The goal here is to create a community infrastructure that supports ongoing community-driven policy and systems changes to address birth disparities, while correcting for a history of damaging institutional practices and establishing a sense of self-efficacy within the village of support for Black moms and babies. By self-efficacy, we mean that we are all empowered to engage in this effort and make a difference in birth disparities. We make up the village and have a responsibility to act within our sphere of influence, whether that's calling a pregnant mom to make sure that she's okay, or taking the essential step to disaggregate your hospital data by race and act on what you find. Supported by public and private funding, we've been partnering on the design, optimization, and expansion of prevention and interventions that disrupt the pipeline from social stress to physiological stress, such as preconception and group prenatal care, doula care, fatherhood engagement, home visitation, and others, as well as clinical interventions through our partnerships with the March of Dimes and hospital quality improvement effort Cherish Futures for Black Moms and Babies. We are also leading a public awareness campaign. We've established a countywide steering committee and community action teams, launched a pooled fund to support the development of community interventions, created partnerships with insurance providers, and supported policy efforts such as SB 464 and AB 2258. And our healthcare providers are such an important part of this village of care and support, and so we thank you for being here with us today. Again, to learn more about the AIM initiative and ways to join our effort, you can find us at blackinfantsandfamilies.org. And with this grounding, we will now begin our training on preterm birth.
Thank you for sharing. It's beautiful. I'm going to be talking about overcoming disparities in African American infant and maternal mortality with an emphasis on preterm birth and the maternal considerations. These are my disclosures, and I have no off-label use of medications. These are the objectives: to describe healthcare disparities in medicine as it relates to maternal mortality and preterm birth, describe the risk factors for preterm birth, and improve and discuss the evidence-based practices that can decrease the risk of preterm birth, as well as what to do if preterm birth isn't anticipated. So we're all very familiar with healthcare disparities in medicine, and these are the seminal resources that have described the ongoing inequities in health, and that compared with whites, Black patients are referred to see specialists less often, they receive less appropriate preventive care, have fewer kidney and bone marrow transplants, receive fewer antiretroviral drugs for HIV, and get fewer prescriptions of antidepressants for diagnosed depression. They are admitted less often than whites for similar complaints of chest pain and receive less medication for common medical and surgical conditions. So it is not surprising that we would also have reproductive and perinatal health disparities. Women of color, particularly Black and Indigenous women, have higher rates of maternal mortality and severe maternal morbidity. They have increased rates of diabetes, hypertension, obesity, and cesarean delivery. They have increased rates of OB complications such as gestational diabetes, preeclampsia, and cardiac disease, and they have increased rates of preterm birth, specifically spontaneous preterm birth, spontaneous rupture of membranes, and preeclampsia, which could be an indicated cause for preterm birth. If we look at maternal mortality by race over time, we can see that it has been increasing. It is currently 17 per 100,000 for the United States, and whereas for Black women, it's 38 per 100,000 live births, and for American Indians, it's 25 per 100,000 live births. So both Blacks and American Indians have a maternal mortality rate that is 3 to 4 times that of white Americans. This is the data for California, which shows that actually in about 2005, we implemented some population-based clinical care protocols directed towards the management of preeclampsia and the management of postpartum hemorrhage, and actually saw a decline in the rate of maternal mortality. And this decline was most recognized in African Americans, as demonstrated by the red line. If you look at the maternal mortality by age, age is a significant risk factor, with women over 35 being at increased risk, which is the top line here. And obesity and overweight is a significant risk factor, with 80% of women who experience maternal mortality being overweight or obese. These are the different causes of maternal mortality by year, and you can see that over time, it has, the management of hemorrhage and hypertension has gone down, and now the leading causes of maternal mortality are actually cardiovascular disease and stroke. We've sort of realized that most of this is, we've been focusing on the individual, but as we get better at managing individual health risk, we're finding that the social determinants of health is another big opportunity. So what do we know about women of color is that Black women are different, and therefore we should probably be treating them differently, as both as an individual and as a group. And how that difference is measured or characterized is yet to be determined. We don't really think it's genetic. It might be metabolic or proteomic, and we definitely know that there are some social structures that are responsible for our different outcomes. But it doesn't matter if you look globally across the world, the maternal mortality risk for women of African ancestry is greater, as demonstrated in Africa, but it's also noted in every country that Black women migrate to. And this disparity is not adequately defined by socioeconomic status or segregation. So what we have to do is to look from places, at what the best practices are and learn from places where maternal mortality is improving. And believe it or not, that's in the developing countries. They've made huge headway in improving maternal mortality. And the biggest way that they've done that is by capitalizing on ongoing political will. So the preamble that was given to us from Brandy and the whole emphasis of the Black Lives Matter and Black Mamas Matter initiative are very important for maintaining the ongoing political will. The other thing that's really important is making sure that there's a skilled and interested birth attendant, because they impact the provider attitudes and provider communication. And this is being realized in the community as an increased prevalence of doulas. And they've also been shown to decrease not only cesarean birth, but decrease preterm birth, which we'll be talking about. Contraception is a big one. If we can prevent pregnancy, we can prevent some of the adverse outcomes of pregnancy. So we want to address wantedness and avoid unintended or mistimed pregnancy. We also want to address education and economic empowerment so that we decrease pregnancy and teen births, who are huge contributors to preterm birth. We want to develop a research program to isolate best practices for standardized treatment of Black women, comparable to the goals of emerging guidelines for the treatment of hypertension, diabetes, and obesity. And recognize that being Black in and of itself is a significant risk factor for all of these conditions, and therefore should trigger enhanced scrutiny and care and sticking to treatment protocols. Brandy talked about the weathering hypothesis, which is a very sophisticated theory that basically says that there's cumulative exposure to economic disadvantage, and that extra burden sometimes just tips us over into an adverse health event. The stress, inflammation, or the allostatic load when faced with an acute event, women of color may have less resources to recruit, combat, or overcome, and in general are just less resilient because of additive stress. So focusing now on preterm birth and acknowledging that much of this work has been collaborative efforts between March of Dimes and the California Public Health Department, as well as many community experts. How do we decrease preterm birth? Well, it's relying primarily on the social determinants of health and looking at each of these different layers in the health process. The individuals, meaning the patients and the providers, the hospitals, the community, and early delivery, which is about 450,000 babies in the United States. 15 million babies are born preterm around the world, which is approximately 1 in 10 births, and 80% of preterm births are unanticipated. If you look on an individual level, there are multiple risk factors for preterm birth. I've highlighted in bold those things that are potentially modifiable. Having had a preterm birth previously is a significant risk factor. If you're pregnant with more than one child or have multiple gestation, if the interval of birth is less than 6 months between pregnancies, if you have an IVF pregnancy, even if it's a singleton, you're at increased risk for preterm birth. If you have an abnormal uterus or problems with your cervix or bleeding from your placenta, you're at increased risk for preterm birth. If you smoke or use drugs or drink alcohol, you're at increased risk for preterm birth. Being pregnant with a baby that has congenital anomalies increases your risk, as well as having an infection of the amniotic fluid or the genital tract, such as sexually transmitted disease, can deliver early. If you have a history of multiple abortions or miscarriages, if you suffered trauma, such as a motor vehicle accident or domestic partner violence, and if you have pregnancies below the age of 17 or greater than 35, you're at increased risk for preterm delivery. Looking at this graph, about 30% of preterm births are indicated or are due to either spontaneous rupture of membrane or spontaneous labor, or what we call idiopathic, which means idiots, we have not quite figured out the pathology of what's causing it. But what we do know is that a common pathway is both stress and inflammation. And so somewhere the cortisol starts the inflammatory cascade, which ultimately causes contractions and cervical change. If we look at preterm birth by race, and this is California data, we see that it is higher for African Americans and American Indians. So evidence-based strategies to decrease preterm birth. One of the big ones is smoking cessation. Smoking is associated with fetal growth restriction, abruption, preterm birth, and SIDS. In 1990, the Surgeon General determined that if you stopped smoking before you got pregnant or within the first trimester, you could reduce your risk of that of someone who never smoked. A meta-analysis of smoke-free legislation in America and the UK found that there's a 10% reduction in preterm birth by this population-based intervention. And so it's important to remember that secondhand smoke is as bad as firsthand smoke. Another strategy is to increase or optimize birth spacing and pregnancy intention. 50% of births are unplanned or unintended, And 30% of women have short birth spacing, which is defined as a second pregnancy in less than 18 months. The ideal time is between 18 and 24 months. So 2 years apart is an ideal time. So one of the things we want to be sure you ask is what we call the one key question. And this is true not only for OBGYNs, but for all healthcare practitioners. You should be asking your patients, what is your reproductive life plan? And are they planning to be pregnant in the next year? And if the answer is no, you want to be sure to offer a no-cost, FDA-approved contraceptive method. The other thing we want to do is we want to remember that Well Women Visits includes preconception counseling, and that for African American women, this is particularly important in order to decrease the risk of preterm birth. You want to optimize the medical conditions, which we've talked about. We want to stop smoking, drinking, or using drugs. And we want to make sure that women are taking folate, even if they're on contraception. The other thing we want to emphasize is that the Well Women Visits include interconception care, which is the time that starts the day after delivery throughout the postpartum period into the next pregnancy. For African American moms, this is an especially good time to make sure that she understands her increased risk for subsequent preterm birth, cardiovascular disease, depression, and demands for the medically fragile premature child. This is especially important if the woman had a preterm birth, because they're at significantly increased risk for recurrent preterm birth with subsequent pregnancies, and you want to encourage them to seek treatment early. Providers need to assess the social situation, their social support, the social barriers, and make appropriate referrals for Black women to public health programs such as Black Infant Health, WIC, home visiting, and to consider referrals for stress management if desired. And I want to emphasize that this is true for all Black women, not just Black women on Medicaid. Studies have shown that it doesn't matter how affluent you are or how well educated you are, you're still at risk for both maternal mortality and preterm birth. You want to emphasize to patients that if they think they're experiencing preterm birth, they need to be seen, and this needs to be assessed right away. I tell my patients all the time, I cannot diagnose preterm labor over the phone, and many of the symptoms of preterm labor are common pregnancy complaints. If women have had a prior preterm birth, they should start the conversation off by saying, I've already had a preemie, to make sure that their concerns are taken seriously. I'm emphasizing less triage over the phone. You really need to see that patient. And there are excellent studies that show group prenatal care can impact preterm birth rates. And I think it's largely due to the social support that happens in group care. I know that having twins is cute, but they are a considerably high risk. So if you're having IVF, you want to limit to 1 embryo. It is not cost effective to have 2. 60% of twins are born preterm, with the average being at 35 weeks. 50% of twins are born at less than 37 weeks, and 10% are born at less than 32 weeks. Providers should avoid inductions before 39 weeks. We want to encourage the use of low-dose aspirin to prevent preeclampsia in high-risk women. I know you guys had that lecture last time, but if you're African American and you are pregnant, you should be on baby aspirin, unless there's a medical reason why you should not be taking aspirin. We want to improve access to 17P for women with a prior preterm birth. Studies have shown that it decreases recurrent preterm birth by 50% when compared to placebo. You want to have the opportunity to measure cervical length at the 20-week anatomy scan, and if the cervix is measuring less than 2.5 centimeters, there's a 20% risk of preterm delivery, and therefore the patient should be offered progesterone or cerclage in order to decrease her risk of preterm birth. Evidence-based strategies at the hospital level, including a standardized protocol that they do for all women, irregardless of race, ethnicity, or risk. If you do the same thing all the time, you're not going to miss anything. Prenatal classes should be offered free in order to educate about the symptoms of preterm labor and what to do. There should be less triage over the phone. Go see the doctor or come in. Again, I tell my patients, I cannot see them too many times. Don't be embarrassed by coming back and having us reassure you that nothing is wrong. We want to ensure access to postpartum LARC. It would be great if women who don't want to have another pregnancy in 2 years goes home with a long-acting contraceptive method. There are some barriers to that from the policy level and the reimbursement level. If you have a preterm delivery, does the hospital have a special discharge education program? Do they offer special follow-up? Right now, if you're being discharged with congestive heart failure, there are many social things that are put in place to decrease the likelihood of a readmission in 30 days. What social things are being put in place for women who've had a prior preterm birth to decrease the likelihood that they have another? What should the health plans do? Health plans should recognize that well women visits is plural. It's not a one visit. It includes the preconception visit, the interconception, as well as postpartum care. Insurers can work with the business community to stop targeted marketing of tobacco in the African American communities. We want to pay for serial cervical length measurements, and we want to remove the pre-authorization requirements for progesterone. Sometimes it can take weeks to get approval, and we want to be able to start it on time at 16 weeks. And then finally, in the same way that we have care managers for diabetes and hypertension, health plans can have perinatal care managers in order to assist high-risk moms. Public health can do things like this meeting and partner with community partners. They can also have strategic health information campaigns regarding the risks, campaigns about birth spacing awareness. One of the things I think is really important is campaigns to ensure that women know that having a preterm birth is not normal. I've had patients come to my office and I tell them that they're at risk for preterm labor, and they say, oh, it's no problem. My last baby was 34 weeks and she turned out just fine. Having a normal outcome doesn't mean that preterm is normal. And so we want to really emphasize that normal gestation is a term delivery after 37 weeks. We can prepare packets on social supports and resources for providers to give to patients. A lot of providers, especially in these high-end practices, don't know about the social services that are available for women, especially African-American women. We want to report data outcomes stratified by race. If you're not stratifying by race, you're not aware of the inequities. And to have a backbone team to reach out and coordinate with the social services, including housing, transportation, community safety, and food access. We want to meet with key businesses to identify the role and opportunities for improving birth outcomes, especially in the work site initiatives and incentives. And finally, what can the community do to support African American moms? They can create a caring circle around her. There's a saying out there called 1,000 acts of kindness. Provide moms with meals, babysitting for other children while she takes herself or a preterm baby to appointments, help with transportation to appointments. An opportunity to just take a nap would be an act of kindness. And importantly, we want to educate all generations, and particularly men, about the importance of birth spacing so women are supported in their reproductive life planning goals. So do these evidence-based strategies work? And the answer is yes. Australia implemented 6 of these proposed strategies in a nationwide campaign called The Whole 9 Months. And what they found after a 12-month evaluation is that they were able to reduce preterm births by 7.6% compared to the prior year. It's estimated that 200 preterm births were prevented, and they concluded that a multifaceted geographic-based preterm birth prevention program in a relatively high resource setting can significantly reduce the preterm birth using existing knowledge with an effect size of 7 to 8%. So as Nike would say, we need to stop talking about it and just do it. So this is a summary of the premature campaign interventions, and I'm crediting the March of Dimes with summarizing this. And then lastly, I just want to conclude, if you or your friend calls you and asks you what should you be doing if you've been diagnosed with preterm birth, I want to emphasize steroids, steroids, steroids. If you're less than 34 weeks, steroids, steroids, steroids. There are some studies that suggest that there's a benefit even at less than 37 weeks, and it's been found to decrease respiratory problems, decrease overall neonatal mortality, and decrease other complications such as intraventricular hemorrhage and necrotizing enterocolitis. There are some maternal side effects, the biggest of which is hyperglycemia, which I emphasize can be treated, and some newborn side effects, which is opposite of that, and that's hypoglycemia, again, which can be treated. If you have ruptured membranes less than 34 weeks, you should receive antibiotics. It's been shown to decrease the maternal risk of infection and to prolong latency or the duration of pregnancy. And then if it's less than 32 weeks, then the mother should get magnesium sulfate for neuroprotection. We believe that giving magnesium sulfate decreases the risk of cerebral palsy. And then finally, should you receive medications to stop contractions? And this has been evolving over the years. Every 7 years, we change our mind. But if you're going to get medication, right now, the drug of choice is nifedipine, and probably only during the steroid window. Indomethacin is also a candidate if you're less than 32 weeks. We don't give it after 32 weeks because of concern about premature closure of the ductus, which could have an impact on the postnatal transition. And then many of you might have taken terbutaline when you were pregnant back in the day, but that has fallen largely out of favor and is not used now. And then I would be remiss not to wear my MPH or public health hat if I didn't emphasize that the best way to avoid maternal mortality and preterm birth is primary prevention or not getting pregnant at all. And so this is a cartoon that says, see what kissing can lead to. Now I understand that we're gonna go to Dr. Aline before we open up for questions. So I thank you for your time and look forward to questions. Claudia?
Okay, get rid of that. All right, good afternoon, everyone. It's Dr. Claudia Allen speaking, and I'm going to be talking about prematurity, complications, and clinical strategies for managing preterm infants. I do not have a slide that says I have nothing to disclose, but I do not have anything to disclose. And this talk really will not concentrate on differences in outcomes for preterm infants based on race. I'm really just trying to give you a flavor of what it is like, what I deal with when I care for an infant who ends up in the NICU due to prematurity. All right, so first off, let's be clear that everyone understands the definition of prematurity. Dr. Gregory has alluded to this. A preterm infant is an infant who is delivered before 37 weeks gestation. That's 259 days from the first day of the last menstrual period. Now we classify babies based both on gestational age and birth weight. So a preterm or premature infant, again, is born at less than 37 weeks completed gestation. And we have what we consider to be late preterm infants. These are infants who are born at 34 weeks, 0 days to 36 weeks, 6 days completed weeks gestation. And I mention that only because these babies tend to be a bit bigger. There was a time when instead of calling them late preterm, we called them near term. But more recent research has made it clear that this is a population that has some significant morbidity associated with it as well. And so they get called out in their own category. Then we move on to birth weight classification. Low birth weight infants are those who weigh less than 2,500 grams. That would be 5.5 pounds. Very low birth weight infants weigh less than 1,500 grams. That's 3.3 pounds. And extremely low birth weight infants have a birth weight less than 1,000 grams. That's 2.2 pounds. So just to give you this kind of visual picture of it, looking at the distribution of birth weight categories in California for the year 2018, 93% of babies were not low birth weight, about 6% were moderately low birth weight, and 1.4% were less than 1,500 grams. That really looks like the same pie chart when you compare that to the distribution of gestational age categories. 91% were not preterm, so they're born at greater than 37 weeks. 7.5% were moderately preterm, born at 32 to 36 weeks. And then the very preterm, less than 32 weeks gestation, was 1.3%. So what are the problems of prematurity? Well, really it's related to adapting to being outside of the uterus because your organ systems are immature. And every last single organ system is immature and a potential problem. It's associated with 1/3 of all infant deaths in the United States, and it accounts for 45% of children with cerebral palsy, 35% of children with vision impairment, and 25% of children with cognitive or hearing impairment. The risk of complications increases with increasing immaturity, and those infants who are born at 25 weeks gestation or earlier, so we're talking I'm born 15 weeks too early or more, have the highest mortality rate and the greatest risk of severe impairment. But I do, again, before I move on, I want to bring us back to the problems of late premature infants. And I mention it again, it kind of dovetails with what Dr. Gregory said, and I was happy to hear her say that because too often I think that obstetricians are a little bit cavalier about late preterm infants and the consequences of delivering at 34 to 36 weeks gestation. Mortality rates within the practice of neonatology have decreased significantly, and many of us look at late preterm infants as basically a chip shot. This should be okay. But although we have this risk of decreased complications, even moderately preterm infants are at risk for significant morbidity. Respiratory distress, hypothermia, meaning they're too cold, hypoglycemia, their blood sugar levels are too low and need to be managed, hyperbilirubinemia or jaundice that needs therapy, and then feeding difficulties because their ability to suck and coordinate swallowing has not yet matured to the point that it should. Okay, where are we here? All right, so key thing, first off, if we can prevent prematurity, we'll be in good shape. Those are the issues that's the issue that Dr. Gregory just addressed. So we need good obstetric management. We need to recognize and treat maternal illness, recognize and treat maternal infection, inhibit preterm labor if that is possible, and give steroids to facilitate lung maturation. I'll just add as a comment, the other thing that steroids does in addition to facilitating lung maturation is that it helps to clear lung water. So one of the problems that we see as a complication very frequently of late preterm delivery is a condition called retained fetal lung fluid or transient tachypnea of the newborn. So when babies in that population get steroids, what happens is that we are less likely to have an NICU admission based on the fact that that baby is breathing quickly, huffing and puffing, and needing oxygen therapy or some non-invasive respiratory support. So I'm gonna go on now to talk about the initial acute problems of preterm infants. I'm only going to mention long-term problems very, very briefly. Okay, so what is the spectrum of problems in premature and low birth weight infants? Well, they are protean. Every single body system can be impacted. I think that most folks probably are familiar with the respiratory complications, but there is not a single body system where if something can go wrong, it does not go wrong. And so my job as neonatologist is to try to manage all of these potential problems in a manner that gives us an infant who has the best possible outcome. So let's talk, I'm just going to really just hit some key high points here. So let's talk first about hypothermia, or babies who are too cold. So hypothermia occurs because the babies have a relatively large surface area and they're unable to generate enough heat. If I only weigh 1,000 grams, I don't have enough insulating fat that I can break down to generate heat. Hypothermia is associated with increased mortality. It's also associated with several of the complications of prematurity, including intraventricular intracranial hemorrhage, respiratory difficulties, metabolic disorders, low blood sugar, metabolic acidosis in survivors. So what do we do to try to prevent this? We maintain delivery room temperature at a minimum of 26 degrees centigrade. And I believe that that is about 87 or 84 degrees Fahrenheit. No, I'm sorry, that's too high. 78 degrees Fahrenheit. So as you can imagine, if you're an obstetrician in a C-section in full surgical gear, you're not going to be particularly happy with me when I walk in the room and say, I'm sorry, we have to turn up the temperature. But nonetheless, that really is what's required to be sure that the very low birth weight infants are not hypothermic. We dry thoroughly, we remove wet blankets, we use pre-warmed radiant warmers, and then we use barriers to prevent heat loss. There's basically plastic sheeting, that's a body wrap, stockinette caps, and then warming mattresses as well. And then the infant is cared for in an incubator or radiant warmer that would be servo-controlled to avoid hypothermia. So next big thing are the respiratory abnormalities. And the issues that we generally are dealing with would be neonatal respiratory distress syndrome. Maybe some of the older practitioners in the audience will think hyaline membrane disease. Respiratory distress syndrome is really a consequence of both physiologic immaturity, the inability to produce surfactant which stabilizes lungs, and pathological maturity, because the lungs really have not fully branched out into all of the little air sacs that are quite needed. Neonatal chronic lung disease, and that has many definitions, but the one that we seem to run with the most is oxygen dependency at 36 weeks postmenstrual age. Apnea prematurity. Apnea is a pause in breathing of greater than 20 seconds. It is a developmental maturational issue. So if I'm 34 weeks gestation, I really shouldn't be having a whole lot of apnea prematurity. But if I'm 24, 25 weeks, I may need to be on a respirator simply because I can't get it together to remember to breathe. And then pulmonary hemorrhage, we most commonly see this in extremely preterm infants. So how do we manage this? Well, we would do assisted ventilation. We try now to do primarily non-invasive ventilation, that is not put a tube in the airway, but rather do the work of ventilation through prongs in the nose. So we do nasal CPAP, and CPAP stands for continuous positive airway pressure, that pressure being there to help maintain those lungs fully expanded. And then nasal ventilation, by which I provide breaths through those prongs in the nose. Once an infant is sick enough to need to have a tube in the airway, we can either do conventional ventilation, which is when a ventilator is providing basically breaths the way that we would breathe, or we do high frequency oscillation, which essentially the ventilator is just vibrating the infant's chest. Another newer mode of ventilation is NAVA, which stands for Neurally Adjusted Ventilatory Assist. There are both invasive and non-invasive modes of NAVA. And with NAVA, what we are doing is using the electrical activity of the diaphragm to determine how much we support the infant's breath. So if the baby wants to take a little breath, the ventilator will provide a little breath. If the baby wants to take a big breath, the ventilator will provide a big breath. Surfactant therapy. Surfactant therapy is used for those infants who ultimately need invasive ventilation or those who are on non-invasive ventilation but require a high degree of supplemental oxygen therapy. And to back up again, very simply, surfactant is a fluid that lines the lungs of full-term infants, children, and adults. It allows us to take a breath in and breathe out without having the lungs collapse down at the end of each breath. For preterm infants with lungs that are immature, breathing is like blowing up a balloon from scratch each and every breath. And as you can imagine, that gets old fairly quickly. And then just the whole picture of supportive care is also important to the respiratory management of these preterm infants. All right, let's go on to the cardiovascular abnormalities. Dr. Gregory also mentioned ductus arteriosus, or the problem that I'm concerned about is a patent ductus arteriosus. And to just explain, the ductus arteriosus is a vessel that is open while the baby is still inside the uterus that allows the shunting of blood that has picked up oxygen from the placenta away from the lungs to the rest of the body. Because let's consider it, you're inside, the lungs aren't doing the work of breathing, they need enough blood flow so that they can grow, but they are not doing the work that they will do once the baby is born. So symptomatic PDA occurs in about 30% of VLBW infants. That open vessel shunts blood from the left side of the heart to the right side of the heart. And in doing so, it increases blood to the pulmonary circulation and decreases blood to the systemic circulation. The consequences of that depend on the size of the shunt and the response of the heart and the lungs to the shunt. And so we have several strategies available to us to try to manage this. Sometimes it's just conservative management with general supportive measures alone. You just try to ignore the fact that it's there. We can close it or try to close it if we need to, using medications like indomethacin, good old Advil, or acetaminophen. There are some prophylactic uses of these medications to try to prevent the ductus from opening, and then ultimately surgical ligation. But in all honesty, what I say to parents is, I'm going to do my best here, but the truth of the matter is that the research is not so crystal clear as to which approach is the best one for your baby. And that's because there have not been any large randomized controlled trials that compare these different strategies. You can go to certain academic centers where they would never, ever treat a duct, others where they're only using medical therapy, and others where they're quick to do ligation. So I think that summary of it says that we're still not absolutely sure what we're supposed to do with this problem. All right, the other issue that we can see, particularly in the very low birth weight and ELBW infants, is persistent hypotension. We see hypotension without evidence of shock. And when I say without evidence of shock, the blood pressure is low, but that low blood pressure doesn't seem to necessarily be impacting how the organs are functioning. The baby looks like they're okay, their perfusion is okay, maybe they are still peeing, they don't seem to have any particular consequence to their tone and activity level. And the questions that still need to be answered are, do these infants have worse outcomes? Is there any particular benefit to intervening if there isn't shock? And what is the BP threshold that we should be using? What is the optimal therapy? Well, one approach is to identify what the primary factor is that's leading to low blood pressure and then manage based on cause. So if I have a baby who has had acute blood loss, then I want to treat that with volume expansion. If I have a baby whose heart I don't think is pumping as effectively as it should, a baby who has myocardial dysfunction, then I'm going to use inotropic therapy, medication, to try to make that heart pump more effectively. And if, again, I have hypertension that is due to infection, then I'm going to use inotropic therapy, and I'm going to treat the infection as well. All right, let's move on to the central nervous system, the problem of hemorrhage. So one of the big complications for preterm infants is intraventricular hemorrhage, what we consider germinal matrix hemorrhage, and then intraventricular hemorrhage again. So let me, in sort of plain word description, we have fluid-filled spaces in the brain called ventricles. The ventricles are surrounded by the germinal matrix, which is a highly cellular and highly vascularized region, and that's where the cells migrate out during brain development. It's most active between 8 and 28 weeks gestation. So the infants who are at greatest risk for this are the earliest preterm infants. Those blood vessels there, with this high vascularization, are basically fragile and prone to rupture and bleed. And so that's why this is a problem for them. The severity of hemorrhage in preterm infants is based on the extent of the bleeding, whether it's only into the germinal matrix or extends into the ventricles, whether there's involvement of the adjacent white matter of the brain, an intraparenchymal hemorrhage, and or if the ventricles have become enlarged or distended. The way that we make this diagnosis first and foremost is with head ultrasound studies. And, you know, we're kind of simple people. There's just about everything in preterm care that has a grading is graded on a scale of 1 to 4. So if we only see hemorrhage into that germinal matrix, it's a grade 1. If there is blood in the ventricles, that's grade 2. If the ventricles are becoming enlarged, that's grade 3. And if there is hemorrhage extending into the brain parenchyma, that would be grade 4. And I don't think you need a medical degree to realize that the risk of long-term complications increases as you increase the grade of hemorrhage, with really grade 3 and grade 4 being the most concerning, although we aren't cavalier and dismissing what might be the long-term impacts of grade 1 and 2 as well. So this occurs frequently in very low birth weight infants, those who weigh less than 1,500 grams, and or the very preterm infants that are less than 32 weeks. So what do we try to do? Well, first off, we want to prevent it. So we want to give good care. We want to provide prompt and appropriate resuscitation. We want to manage hemodynamic instability. And then we want to avoid the conditions that impair the brain's ability to really auto-regulate what the amount of blood flow is. So we don't want someone whose blood oxygen level is too low or too high, or we don't want them to have too low a level of carbon dioxide or too high a level of carbon dioxide. There's no specific therapy to limit the extent of an IVH after it has occurred. The treatment then is just supportive. What we're trying to do is to preserve cerebral perfusion, minimize any further brain injury, and detect any early complications. That is, if the ventricles are getting large, I want to know that early on and to follow it prospectively so that I can intervene when I need to. And the major complication of severe IVH is post-hemorrhagic hydrocephalus, where the fluid-filled space basically isn't draining at all, and that sometimes requires shunt placement to manage. All right, feeding. So we have a few issues that relate to the baby's immaturity. Bowel function is immature. The esophageal sphincter does not have great tone. The stomach is small. The intestinal tract doesn't move stuff along as well as it should. Babies, these preterm infants really aren't able to coordinate sucking and swallowing until they're about 33 to 34 weeks. And even then, they may not have it completely under control. We have complicating medical illnesses, and then we have complicating medical interventions. So now we have some approaches. We want to introduce feeds early, that is enteral feeds as opposed to intravenous feeds. And when I say that, we're not really feeding to try to provide the bulk of the baby's nutrition. We provide what we call trophic feeds to really nourish the intestinal tract and, quite frankly, get it used to the fact that it will ultimately have a job to do. We want to use human breast milk exclusively for VLBW infants. So a baby with a birth weight less than 1,500 grams or one born at less than 32 weeks would be fed human breast milk. And if the mom was unable or unwilling to pump her breast, then if she would consent, we would use human breast milk provided to us by one of the breast milk banks. We use feeding protocols with feeding advancement based on birth weight categories. And you want to provide lactation service support so that the mom who wants to breastfeed has as much support and help as is needed to be successful with it and be able to continue it once the baby is out of the NICU. All righty, so other big issue that we are concerned about and have to cope with is the diagnosis of necrotizing enterocolitis, or NEC. So NEC is one of the most common GI emergencies of the newborn infant and happens in about 2 to 10% of VLBWs. Essentially, we have ischemia and death of the intestinal lining, and that's associated with severe inflammation, the invasion of the bowel wall with bacteria that create gas, and then we have dissection of that gas into the bowel wall and into the portal venous system. If you're looking at the abdominal x-ray that I see there, you see that little kind of soap bubbly appearance, and those little soap bubbles are the air that is in the intestinal wall. NEC produces a lot of long-term morbidity in survivors of neonatal intensive care, particularly preterm very low birth weight infants below 1,500 grams. And 10% of these babies are gonna have long-term GI difficulties. So what is the management? Well, we wanna use antenatal corticosteroids primarily to reduce the risk of neonatal respiratory distress syndrome, feed human milk, use standardized feeding protocol, including administration of colostrum. And it's really interesting in trying to figure out why standardized feeding protocols work. We seem to say they slow up the cowboys who feed too fast, and you speed up the laggards who don't want to do it at an appropriate rate. We want to avoid unnecessary and prolonged antibiotic use. We want to avoid those agents that reduce gastric acidity. We want to avoid severe anemia. And the hot topic right now is the use of probiotic therapy. And there is good evidence that probiotics reduce NEC, but we're still not sure what's the right agent, what the right dose is, what's the correct duration of therapy, and whether all of the products that are available to us right now are completely safe. There have been a few case reports of infants who have become septic and bacteremic from probiotic therapy. All right, infections. So late onset sepsis, that would be sepsis after 3 to 5 days of age, is a common complication in preterm infants. One or more episodes of sepsis, and that's a positive blood culture with clinical signs of infection, occurs in 20% of VLBW infants who survive more than 3 days. We can have central line associated infections, staph coagulase negative in almost 50% of those cases. And then the other bad actor would be fungal infection, candidiasis, which accounts for about 9% of cases and has a very high mortality rate, approaching 30%. How do we manage and prevent this? Well, it's hand washing. We all have to be absolutely anal compulsive about our hand washing. We do know that we want appropriate staffing ratios, nursing staffing ratios, that makes a big difference. And we also want to practice good antibiotic stewardship. We want to get rid of the syndrome of culture negative neonatal sepsis where things weren't going well. I did a blood culture, it was negative, but things just weren't going well. So I'm going to treat this baby with antibiotics no matter what. Those days are gone. Okay, retinopathy of prematurity, or ROP. So when preterm infants are born, the pattern of blood vessels in the back of the eye, the retina, the light sensitive part, is not yet mature. And these infants can have a disease where those blood vessels proliferate rapidly. And when they do so, those vessels are fragile and prone to rupture and bleed. Probably, at least for me, the most famous victim of retinopathy of prematurity, who was blind as a consequence of it, is Stevie Wonder. The incidence and severity increases with decreasing gestational age and birth weight. So we screen babies who are born at a birth weight less than 1,500 grams or gestational age less than or equal to 30 weeks. We want to maintain target saturation ranges because we know that the extremes of blood oxygen levels increase the risk of ROP. And then treatment is based on disease severity. Depending on what the ophthalmologist is seeing, they can treat those vessels with laser photocoagulation. They can inject an antivascular growth factor agent, and the choice is determined by the experience and preference of the treating ophthalmologist. Where I practiced, the intravitreal injection is used quite infrequently. So what about prognosis? So prognosis is related to gestational age at birth and birth weight. The survival rate for infants who are now born at 24 weeks gestation is 40%. So if you're 16 weeks early, you have a 40% chance of going home. 5 to 10% of infants with birth weight less than 1,500 grams have major disability, such as cerebral palsy, developmental delay, blindness, or deafness. And well, maybe it's not obvious, but the risk does increase with decreasing gestational age and birth weight. Long-term complications, and I'm not going to go into this in any detail, you can have the risk of recurrent hospitalization, most common cause being respiratory disorders, pneumonia, RSV infection, exacerbations of chronic lung disease. And we have our neurodevelopmental disabilities, fine or gross motor delay, and cerebral palsy, sensory impairments, vision or hearing loss, behavioral and psychological problems, impaired cognitive skills. Another problem for preterm infants is growth impairment. When you're looking at growth curves, we're doing better than we were, but it's not unusual for preterm infants to be small when they leave the hospital, and they stay small compared to their peers. And then whatever are the other chronic health issues that were a consequence of the issues that complicated their NICU stay. Okay, so I would be remiss if I didn't talk to you a little bit about shared decision-making. First issue is, what are the prenatal considerations? So when I'm asked to talk to a mom who is getting ready to deliver preterm, what we talk about is what survival rates are and both these short and long-term complications, in addition to giving them some idea of what life will be like during this stay in the NICU. But I think one of the most heart-wrenching things to do is to determine parental wishes when delivery is anticipated near the limit of viability. And we talk now about the limit of viability being as low as 22 to 25 weeks gestation. Approximately 0.5% of all births occur before the 3rd trimester of pregnancy. These early deliveries result in the majority of neonatal deaths, and they are more than 40% of infant deaths, and infant deaths being those deaths before the end of the 1st year of life. They're incredibly complex and ethically challenging situations, as you have heard. For example, if you have IVF, you have an increased risk of preterm delivery. Imagine the roller coaster you've been on and through to get pregnant after IVF, and then now to be in a situation where you may give birth to an extremely preterm infant. We want parents to be able to state their preferences, and hopefully that has been informed by information about complications and survival rates. So we do need to have caregiver and parent teamwork. So I wanted to have this quote from ACOG, American College of Gynecologists. In formulating a plan of care for periviable neonates, clinicians should discuss with parents whether their goal is optimizing survival or minimizing suffering. The approach to antenatal and post-delivery care may differ dramatically depending on parental preferences regarding resuscitation. So there are tools that are available to us to help us provide information to parents about what would be expected outcomes. The National Institute for Child Health and Human Development has a tool that you can use to make predictions about what outcomes might be when a baby is being born extremely preterm. I do want to state that these are risks. They don't speak specifically to any individual infant, but this is what we use when we are going to talk to parents in this situation. So I went in and I ran the data for 2 situations. So let's imagine you are pregnant and it looks like you might deliver imminently at 25 weeks gestation. You're 15 weeks early. Your baby is at the 50th percentile in weight for a 25-weeker, that's 725 grams. He's male, it's a singleton birth, and you have gotten antenatal steroids. Well, assuming your baby is actively treated, the survival rate is about 3/4, 76%. All infants, including not actively treated, would be 76%, because the truth of the matter is, the majority of 25-weekers, our care has evolved far enough along that it would be rare that a 25-week infant would not be offered resuscitation. At 18 to 26 months, among the babies who survive, about 1 to 3% would have profound neurodevelopmental impairment. 21 to 32% would have moderate to severe impairment, less than 1% blindness. Again, I think we do a better job now with managing ROP. 1% deafness, 4 to 6% with moderate to severe cerebral palsy, and then cognitive developmental delay anywhere from 19 to 31%. Look at how this changes if you are an additional 2 weeks early. You're 23 weeks, your average weight, 600 grams, you're male, you're a singleton, you got your steroids. But now if you're receiving active treatment, your survival rate has dropped from 3/4 to under 50% to 40%. We can include here not actively treated because depending on the discussion that has been held and what the parents' wishes are, that 23-week infant may not get active resuscitation. Then the average survival drops to 33%. And when we look at those outcomes at 18 to 26 months, our profound neurodevelopmental impairment has now increased to 5 to 6%. The moderate to severe impairment is at 37 to 52%, so as many as half. Blindness is still good, less than 1%. Deafness at 2 to 5%. More moderate to severe cerebral palsy at 9 to 15%, and more cognitive developmental delay at 35 to 46%. So for those women who come in periviable status, to make it clear every week that we can keep you pregnant, the better our potential outcomes are going to be. There's a big difference between 23 and 25 weeks. You know, the difference between 30 and 32 isn't that big a deal, but 23 to 25 makes a big deal in terms of expected outcomes. Okay, and then finally, I hope I haven't left you thinking that this is just the absolute utter hideous experience for anyone to have, because there is an incredible amount of joy in the NICU. What we try to do now is to practice family-centered care. That kind of family-centered care is good terminology across the board with all disciplines of medicine. But the principles that guide us is that we have to recognize that parents are a natural part of the team. We want them present as caregivers, and in order for that to happen, the NICU has to have a welcoming atmosphere, and we have to have supported unit policies. So that means that, you know, we have very liberal visitation, as in 24/7, that we are open to family visitation. So you can bring in those siblings no matter how old. Now that's if they're well behaved. If your toddler starts screaming, I do want you to walk out the door with them. COVID-19 has really had a significant impact on this because of limitations to policy, to visitation, and we're all understanding what the current circumstances are. We want parents to participate in rounds. That's morning rounds, so as we're coming around as a team and we're getting reports from nurse and respiratory therapists, the parents are there to hear that, and as well to participate in our weekly multidisciplinary rounds. It really does improve parental empowerment and it increases transparency. We encourage kangaroo care, that's skin to skin care for both the mothers and the fathers. And there really is no baby who is too small to have skin to skin care. They can sometimes be too sick, but a baby who even still needs a tube in the airway and is on the ventilator can have skin to skin care. And then we want to, as if possible, you have the kind of facility where you can encourage rooming in. I practice in a unit that has individual rooms for the infants. Problem is the rooms aren't that large. It's not that comfortable for a parent to stay overnight. And so I don't encourage that as something that they would do every day. But certainly if they wanted to sit there 24/7, they could. We have a bathroom there that's available to them to shower. And so with that, I will conclude.
Thank you so much, Dr. Eileen, for that very thorough tour of the preemie experience. I think even for the physicians who are on the line who are not neonatologists, they probably learned a lot about what that experience is like. You know, decisions that have to be made, problems you see in the first few days, if not even the first few hours. Overwhelming for physicians, perhaps, but consider the mother and the family. And so we're very fortunate to have Ms. Jessica Wade who can share that experience. Thank you.
Hi, everyone. So my name is Jessica Wade, and before I get into my slides, I really want to share my birth story and my experience with the NICU, and then I'll get into what we're doing with Mighty Little Giants on helping with the patient experience. So my birth story starts all the way at the beginning. When me and my husband found out that we were pregnant, we were so excited. We like threw a party, we were so excited, and we go to our first doctor's appointment. And when we get there, the doctor's like, okay, you know what? You're pregnant, but you're pregnant with empty sacs. So we need to do an emergency DNC. And so I'm like, okay, hold on. What does that even mean, right? So she said, you're pregnant, your hormone levels are extremely high, but I don't see a heartbeat. So we want to go ahead and do an emergency DNC. And so I asked, what does that mean? You know, exactly. And she went over what the DNC was. And my husband said, you know, that sounds a little invasive. Is there any way that we could wait a couple of weeks, or what can we do? So we scheduled the DNC a couple weeks out, and prior to the procedure, you know, they do an ultrasound. And not only did she find one heartbeat, but she found two. So in my mind, I put myself in a young woman's mind, like, oh my goodness, what if I would have went off of my emotion, did what this doctor said, and just had the DNC? I would not be able to experience what I'm experiencing. And so, but one of the baby's heartbeats was very slow. So we knew something was, either the baby was going to vanish or something was going to happen, we would miscarry. So this is I'm about 8 weeks pregnant at this time. And between 8 weeks and 21 weeks pregnant, I went to urgent care 7 times at 2 different hospitals because I knew something was wrong with my body. Every time I went to urgent care, I left with no resources. I left with, you know, put your feet up. At this point, the other baby's heartbeat did vanish. So I was just, you know, I was extremely nervous about the other twin. And, but I listened to my body and I knew that something was extremely wrong. So at 21 weeks, something was wrong. My water broke at 21 weeks pregnant. And so at this point, the doctor tells me I have 2 options. So what I can do, I can either go home and put my feet up, or I could either stay here in the hospital and just wait and see what we can do within the time there. So I decided, as long as this baby has a heartbeat, I'm gonna be on hospital bed rest, even if I can't get up to take a shower, whatever I need to do. And so I ended up being on hospital bed rest for 58 days. And throughout that time, I went through a lot. I never leave this out of my story because you just never know what people are going through outside of the hospital. During that time, me and my husband, we lost the home we were living in. My husband lost his job. He got laid off. I wasn't working. I was on bed rest. So, you know, I was on leave. And so many outside stressors affected my stay in the hospital. So you just never know what's going on with people that you're servicing. And, you know, nurses change every 12 hours. Some cared, some didn't. And to the point where when I was actually in labor at my 27 weeks, I was telling the nurse, you know, I am in pain. I've been here for a while. I am hurting. Something is wrong. You know, this is different. And so she was like, no, you're fine. You can't be hurting that bad. I'm looking at the monitor. But I told her, look at me. Like, I'm sweating, I'm crying, I'm extremely uncomfortable. Look at me. And my husband was on the train. So I called my mom, and mind you, guys, we live 100 miles away from family. We were in Lancaster at the time. I called my mom in Santa Ana and I said, something is wrong and nobody is listening to me. I need you here. My mom got there in like 30 minutes. I don't know how it happened, but she made it. And so when she got there, she had to cause a scene for the charge nurse to actually check me. By the time they checked me, I was 10 centimeters dilated. The belt on my belly didn't pick up anything. It was broken. And so I literally had my son at 27 weeks and 6 days in the hallway, pretty much because nobody listened to me, or nobody listened to, didn't take my pain seriously. So our son was born at 27 weeks and 6 days. And, you know, he was doing okay in the NICU on February 27th. That's his birthday. He was doing okay in the NICU. We went from the incubator to an open crib. So we were making some progress. But after a while, my husband noticed, he said, you know, it's so crazy. Every time he is getting fed, and he was getting fed through the tube, he would desat. And they're like, no, he's fine. No, he's okay. And he's like, no, something's going on. And the levels, we kept having to get his vent levels turned up. It was just really, really weird. So it turns out he was not okay. He was getting fed so much to the point where he aspirated, and he had a complete respiratory failure on Easter Sunday. He had a complete respiratory failure. It caused him to get pneumonia, and it caused him to get a blood infection, which he had to get transferred to Children's Hospital right away. And I say that to say, to listen to the parents that you're working with. You know, medical terms is like a foreign language to me, but I know my instinct, and it's important to listen to not only the mothers, but the fathers as well, because they see it all, and it's important to include them in the process. So I'm almost done with my story. As you know, so it's Easter Sunday. They're like, we got to transfer him. I couldn't get in the helicopter. We get on the freeway, you guys, and our back tire pops. Our back tire pops. We are literally don't even have enough gas to get to, financially didn't have money like to get to Children's Hospital. We were gonna make it work, and then our back tire pops. And so I always mention that because you never know what people are going to even get to the hospital, to even get to the NICU. So we finally get there. Marlon, he was extremely, extremely sick. He was on 12 drips at one point. He coded 3 times. They wanted to do ECMO due to his blood infection, but we didn't sign off on that. So he ended up getting blood transfusions. And he was one of the sickest babies in the NICU for a while. But, you know, we kept a positive attitude, and his rounds started off with, it seemed like 100 people, got smaller, 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 smaller. And he made it through. He is now 6 years old. And so from that, I promised that I would give back when I could, because, you know, I've dedicated myself to changing the patient experience. And so I will go over Mighty Little Giants and what we're doing and give advice on what I can. So Mighty Little Giants, let me move this over here, sorry. Mighty Little Giants is a national 501c3 nonprofit organization that advocates for mothers and fathers experiencing preterm deliveries resulting in long-term stays in hospital NICUs. Our mission is to bridge and stand in the gap for families with babies in the NICU by embracing our core values, which are integrity, compassion, and encouragement, ultimately giving them peace in the midst of their storm. And so these are actual pictures of my babies that are some of the babies in my program. The one in the middle, that's me and my son. The one on the right, that's my husband and our son. So our programs, these are the programs that we offer to assist with the patient experience, and I'll let you know what we do. So our NICU support program is what it is. That's NICU support, where we come in and we provide support to the mothers and the fathers experiencing the NICU. And so with that, some do's and don'ts advice that I would give when working with families in the NICU. One, please remember that these families, these mothers, in addition to having babies, their child in the NICU, they are grieving. They're grieving their birth experience. They're grieving not being able to have the maternity photo shoot. They're grieving not being able to take their baby home. They're grieving not being able to hold their child after birth and letting them latch on. They're grieving so much. Always keep that in your head, because you don't know what they're going through, and they're grieving an experience that they thought they would have. And so with the NICU support, we go into hospitals, we sit and we talk. There's something that's so powerful that happens when you get people going through the same storm in the same room. And I will also advise, speak their language. Rounds are scary. I didn't understand what was going on. Speak their language and try to start with something positive that you can say about the baby, because when you do that, you create an atmosphere of like, okay, we can get through this. So that's our NICU support program. Then we also offer life after the NICU. The day our son was discharged from the hospital was the best day and the scariest day of my life, because these babies go from an environment that is so controlled to something where you have to create your new normal. And I was grateful enough to be able to stay at the Ronald McDonald's house for a couple of months. My son was in the NICU for 143 days. I don't think I mentioned that. And so going back home was scary. Like my marriage, we were having issues. I mean, like just different things that cause stress I was going through at home by myself. And now I have to bring this baby home. My son came home on oxygen and he had a heart monitor. So with the Life After the NICU program, we get the moms together and we just say, how are you doing? Without, not the wife, not the mom, how are you doing? You know, these babies, the day they're discharged, that's kind of like the first day for us. And it doesn't stop when you leave the hospital, it just starts. We have moms who, for me in general, I couldn't go back to work because daycare was crazy expensive. My son had oxygen and he had a heart monitor. So whatever daycare facility he went to would have to provide one-on-one support. my son is 7. He has a heart murmur that's like a pin dot now, and he has chronic lung disease. So right now in these times, I'm terrified. And also with, as far as the delays with some of these babies, you know, he will be 7 and he just got his first wiggle tooth. He hasn't lost a tooth yet. We celebrated that, by the way. So just know that the day that the babies leave, that starts for the families. And then we also have our Mighty Little Angels program where this is for families whose babies don't make it out of the NICU. You know, in the hospital, you sign the birth certificate, you sign the death certificate, and you get, you know, resources, but you don't get that much like support, like follow up. You might get one call from the social worker after, but after that, there's not much. So, and what I don't do is I don't speak to something I haven't experienced. I've never lost a child. I've never lost a child in that way. I've never delivered a stillborn or anything. So I do not speak to that, but I do have mommies in my program who have. So that we link them up and provide peer-to-peer grief support. And I think that's something so amazing that if more hospitals implemented that would help a lot of these moms get through. So we're expanding our programs. So the preventative support program, what that looks like is, for me, for example, when I went to urgent care 7 times, I left with no resources. And so by providing resources for your families as soon as they leave, especially the moms who come in who aren't to the point where they can stay on hospital bed rest, they will fill out our intake form, and from there we'll jump in right away. Because if you send a mom home and you tell her to go home and put your feet up and breast, that's impossible if she has other children at home. So we'll come in and ask them, do you need somebody to help you pick up your groceries? What do you need to eliminate you getting up? And what stressors can we eliminate off of you? And so that's something that's so important because you just don't know how the mother's household is. Lactation, education, and training. So this one is near and dear to my heart because after I had my son, you know, my dream was to breastfeed my baby and give him that liquid gold I've heard so much about, you know. And when I met with the lactation specialist, I met with her a couple times, and this day she might have been having a rough day, but she told me, you know what, it's too hard for you. You need to eat, the baby has to eat. Let's do formula or let's do donor breast milk, you know. And so for me as a NICU mom, I can't help my son in any other way. The only way I can help him is to provide this liquid gold that is like medicine. There's medicine for him. And that stigma stayed in me to the point where when I had a full-term baby who didn't want to exit the womb, I didn't even try because I said, you know what, it's too hard for me. And so I decided that I was going to become a CLES so that I can really, really give that compassion and that love and support that these moms need in this time and let them know that your body is amazing. Like you can do this. There's nothing that you can't do, and teach them different relaxation strategies to get that going. And then also doula services and postpartum care. Doula, so I am now a certified doula and I'm so excited about it. But the reason I wanted to do this because if I had an advocate from the beginning of my pregnancy, I believe it would have turned out totally different. And so now I'm working with moms who are on bed rest, prenatal bed rest mommies, and then also providing postpartum NICU support, doula services for NICU mommies. So this is a little background about me. These are some of the partners we work with, and these are some of the committees and boards that I'm on. I do work closely with Children's Hospital, and my education is in early childhood administration. So with our Life After the NICU program, we work with our mommies on the child's milestones as well. And then this is my doula flyer, you guys, and that's my son, Marlon, at the bottom. I always try to throw him in somewhere. He's amazing, and he doesn't have any, he's okay right now. He doesn't have any delays. He's doing amazing. He's off oxygen. You would never know. He's such a big boy. He's in like a size 10, 12. So, so yes. And then this is my contact information. I hope my experience helped you guys. Thank you for your time.
No, thank you very much for your time. This was an amazing story to share with us. I think as providers, we really don't oftentimes have an opportunity to hear the experience at this level. And so now we're going to go to our final presenter, Ms. Mashariki Kudumu. I would say to her, given all that we've heard today, what are our next steps?
Thank you so much for having me. It's really an honor to follow Jessica and her story and all the work that she's doing right now in LA and throughout the county. So just, it's hard to follow her, but I'm just excited to be here and to just let you all know, we've heard a lot of information today and just want to give you all some information regarding how, how to, what are some of the resources and programs that we have at the March of Dimes to help families that have been impacted by preterm birth. I have no financial disclosures, and these are my objectives. And March of Dimes, by way of introduction, we lead the fight for the health of moms and babies. We are one of the oldest and largest organizations around mom and baby health. We started back in 1938, FDR around polio, and then once the polio vaccine was developed, then we really changed into looking at how to improve perinatal health. And a lot of our research and advances have gone to improving families and care in the NICU. Since about 2005, we've been really focused on preterm birth and really elevating now most recently how the impact of preterm birth is in communities of colors and equities and what we need to do to achieve that. And the reason why we're so focused on preterm birth is because it is an urgent medical and public health concern. Preterm birth and its complications is the #1 cause of infant death. The causes of preterm birth and the long-term impact are huge and have impacts not only for the families in terms of complications that it can include, as some of our presenters talked about, cerebral palsy, intellectual disabilities, and blindness. But there's also too, as Jessica said, once you leave the NICU, that doesn't stop, right? There's the emotional impact, the educational impact, the societal impact, and that impacts all of us. And as well too, there's huge economic factors. So the care of caring for babies that have been born preterm is about $3.6 billion annually in California, which is $75,000 per birth. Per baby that's been born preterm in California. And we know there's racial inequities, and some LA County data here, which shows that Black moms who are at a rate of having a baby that's been born preterm 66% higher than white moms. And so it's just not impacting all of us, it's impacting our communities of color, and we are here to really stand in the gap and make these changes. And so how can we change? How can we improve the health of moms and babies and achieve equity? March of Dimes does it in a multi-pronged approach by accelerating the use of evidence-based interventions, addressing social determinants of health, and advancing research, advocating for policies and legislation that protect families, and as well as partnering for collective impact. Because we know we cannot do this by ourselves. We know that we need our partners, both nationally and locally. And so partnering with AIM, partnering Cherish Futures, partnering with Mighty Little Giants, is we know that we need to all work together to move the needle. And so some of the research that we have, so March of Dimes has 6 prematurity research centers. We have 5 in the US and 1 in England. Our closest one is in Stanford, up north. And so one of the really exciting breakthroughs that's happened at Stanford is the development of blood tests that can identify a mom who's at risk for preterm birth. Is about 75 to 80% accurate. And we really look forward to having this on the market to really be able to prevent a preterm birth. And then when moms know that they might be at risk, to make sure that they're getting the services and care that they need through this time. Across the nation, as well as in Stanford, our research centers are looking at how to address social determinants of health, how to address equity, how to make sure that we move the needle and that we reduce disparities in preterm birth. We also too have a robust advocacy agenda, both locally, statewide, and nationally. We know that we have to have systems change to be able to move the needle, to reduce disparities, reduce preterm birth, and it just is not in the healthcare setting. It really is impacts all over. And so our research agenda, or sorry, our advocacy agenda really does look at how to improve access to care, how to improve the quality of that care, as well as how do we protect moms, babies, and families. And so one of the things that we've been always really committed to is Black infant health and making sure that the program is viable and that the funding for Black infant health is always maintained. So whenever it comes up in the legislature around Black infant health funding, this is one of our first priorities to make sure that it stays. We also too provided legislation, we provided testimony as well as helped write the trailer bill language for the California Perinatal Equity Initiative, which is expanding funding and services for Black infant health. AB 577 will expand Medi-Cal for women who've had a mental health condition diagnosis for 12 months postpartum. And so this is really important to make sure that moms who need the extra support and care can get it postpartum. We also too were supporting the recently passed SB 1383, which is paid family leave, supporting the Dignity in Pregnancy and Childbirth Act, which was brought forward by Senator Holly Mitchell and our partners at Black Women for Wellness. And what this bill does is it requires implicit bias training for all maternity care providers in hospitals, as well as informing pregnant people of their rights for care that is free of discrimination in the hospital, as well as collecting better data around maternal mortality and morbidity. We also are supporting the Momnibus Act on the national level, and the Momnibus is a package of 9 bills at the federal level that looks at diversifying the pipeline around the workforce and healthcare, improving access to care, funding community-based organizations, improving data collection. We also too really are supporting, and this is not a bill, but a new campaign with the CDC Hear Her campaign, which is improved patient-provider communication, because as Jessica said, and so many people have talked about today, right, that women and pregnant people are walking into the hospital, urgent care, and not being listened to by their doctors. So how do we improve that patient-provider communication so that we are being listened to? And you can go to marchyourdimes.org advocacy and learn more about our federal and state advocacy priorities. And as Dr. Gregory mentioned, really in looking at reducing preterm birth is really scaling these evidence-based clinical interventions that prevent preterm birth. And so we know that there are interventions, whether it's first spacing low-dose aspirin or progesterone, that can reduce preterm birth or prevent it. And what we know is that women aren't getting it. And we know that there's also two disparities in terms of racial disparities, so women of color and low-income women are not getting these interventions as they should. And so one of the ways to really increase utilization, that identification first. So we hear all the time that women have had a preterm birth, women have had like preeclampsia or have had like their second preterm baby, and no one talked to them about low-dose aspirin, no one talked to them about 17P, no one talked to them about what they could do to prevent their next preterm birth. And so one of the key things that needs to happen is improve the screening and identification of women in the prenatal care setting, and doing it in a way that's patient-centered and understanding, improving that patient-provider communication and understanding the disparities and really advancing and achieving equity. And so March of Dimes, along with some of our clinician partners and champions such as Dr. Kimberly Gregory, will be releasing our preterm birth prevention toolkit pretty soon, which has tools and guidance and strategies for prenatal care providers to screen, identify, and increase access and utilization for 17P and low-dose aspirin for women who are eligible. And so we're really looking forward to partnering with any of the clinicians on this webinar to bring this training to you and to help you work within your clinics to improve your systems. We also too have our Training Institute, which provides high quality, innovative, interactive, and evidence-based trainings for providers on a host of topics such as communicating in the NICU, helping families who experience loss, looking at our own biases, and impacting and improving equity in the patient experience. And along with that, we have our implicit bias training, Breaking Through Bias in Maternity Care, is now available for hospitals, clinics, and health plans. And what it really is a grounding and an introduction to how structural racism and how bias impacts care that's delivered and received, and helping clinicians, hospitals, and providers to really think about how they can develop strategies and plans for equity and improving access. And so you can, if you want more information, it's a website as well. And then we have a NICU Family Support Program, which looks to improve patient experience and the staff experience in the NICU, as well as educating families and educating the NICU staff, and really having this patient-centered care for the families. And as Jessica and others have talked about, that having patient-centered care and educating, improving education for NICU providers as well as the parents is really important. So in LA County, we have 3 programs, Miller's in Long Beach, CHLA, Children's Hospital, and CHOC in Orange County. And these programs, they serve about 600 families a year. If you have a patient or a friend that you know who's in one of these hospitals, just make sure that they're aware of the program and services. And also too, we have additional handouts and worksheets for patients who might not be in one of these 3 hospitals, but that can benefit from the programs and services. And so you can just go to marchadimes.org complications, and there's a ton of handouts on preterm birth, birth effects, and life in the NICU for families as well as providers. And then we have online support as well. So we have a Facebook group, a Facebook mentorship program as well for moms who've experienced being in a NICU and loss. We have a blog, News That Moms Need, and we have some really great information on the blog, News That Moms Need, regarding COVID and being in the NICU with COVID, bringing your baby home with COVID, and just COVID and breastfeeding. And so really just encouraging you to share this information with your patients and clients. And also too, Unspoken Stories is a platform that we have for women and families to share their stories about pregnancy, preterm birth, and loss, because we know that, as Jessica has done, the more that we share our stories, the more parents and families won't feel alone, and we can improve emotional and social support and access. And then we have a NICU baby app that helps track your baby's feedings and care. You can take photos that you can share with families. It tracks milestones. There's also too patient education information within the app. And so this is for all families, and it's free, and you can just download it. So just make sure you tell your friends, your families, and your patients about it as well. And once again, we talked about Share Your Story is another platform for families to get support online around their experiences with preterm birth, birth defects, or loss. And we have additional patient information on marchadimes.org that is on preterm birth, prevention, signs and symptoms. They're easy to read. There's some infographics as well. So just want to make sure that the clinicians on the line, as well as those who have contact with patients and clients, that know that these materials are on our website. They're free. You can print them out, and most of them are in English and Spanish. And then we have our birth plan, and we updated our birth plan this year for COVID to include questions around prenatal care, birth, and postpartum and breastfeeding during COVID and around this time. And this really is a tool to improve patient and provider education, as well as all have talked about the shared decision making. And so it's on our website, and with Anthem Medicaid, we were really fortunate to have it translated into about 16 different languages. So please, go to the website, find the birth plan, and share it with your patients and your clients. And if you're a pregnant woman or will be pregnant, that you can have this and be able to navigate these conversations with your provider. And then November is Prematurity Awareness Month, and it really is a time for us to raise awareness around the impact of preterm birth on families, and working with providers, and also to just putting forth our research and advocacy efforts. And so we want to let everyone know that we're having a free webinar, series of webinars, November 17th and 18th. That are for not only clinicians, but stakeholders as well. We hope that what these webinars will provide education, information, and to really call us in action to improve outcomes for moms, babies, and families. And so we're looking, we'll have information on updates with COVID and prenatal and maternal health, how communities and clinics are working together, and innovative programs and services for the community to improve health. So we will get that information out to everyone, but we hope you can join us. And then finally, I just wanted to end with this picture, because why this work is so important to me, and why my work at the March of Dimes is dear to my heart. This is a picture of me from my Black graduation at UC Berkeley, go Bears, and my mom and 3 sisters. So I have a sister who went to Stanford, I have a sister who went to Duke, my sister who went to San Diego State, all graduated. I have a sister who's a family physician, I have a sister who's getting her PhD in science education, and we've all had babies 37 weeks or less. And so as we talk about social determinants of health, as we talk about racism, as we talk about the impact of stress on our bodies, this is what it is. So our, fancy research jobs, our private insurance, our home ownership, our vegetarian diets were not protective factors for my sisters and I as we experience racism on a daily, and as we experience disrespectful care in the NICU. So when so this is just for me to really just sort of raise the alarm and know that, this is not, as Dr. Gregory said, it's not about people's diets, it's not about their education. And so really, what are we doing to change systems and policies to improve care, quality of care, and access for all? So thank you so much. Please reach out to me if you have any questions or have ideas how the March of Dimes can partner with you or be a resource to you. We're always here to help and are grateful for our partnership with AIM and the Association of Black Women Physicians to improve outcomes and educate our community. Thank you.
Thank you. I wanted to thank all of our panelists for their participation, because we really want to make a difference and we need the entire village. This right now is a crisis, and all oars need to be in the water to get the best outcomes. So we wanted to thank Mighty Little Giants. I'd recommend that you go to their webpage for resources. We want to thank March of Dimes for the resources they have. I think we all have to go and be advocates for our loved ones and our patients, because this affects all of us. I'm going to start with some of the questions out of the Q&A. And so the first question is, do we have any data on traumatic incidents during pregnancy and its a potential association with preterm births, for example, like domestic violence?
So the answer is yes. It is associated with preterm birth, especially domestic violence, car accidents, adverse historical events like discrimination, and actually poor mental health or post-traumatic stress is also associated with preterm birth, more from the allostatic load perspective. So I can't give you a number, how to quantify how much is associated, but it's definitely been associated.
Thank you very, very much. And then a question for, is Mighty Little Giants available throughout California?
Yes, we are. Oh my goodness. During these times, we've learned how to use the virtual world so much. And so, yes, we are available for moms outside of the area. I actually have a couple of moms out of state, actually. So yes. And I put my contact information in the chat.
And the contact information, I wanted to make sure I give a shout out. What was it, Jessica at Mighty Little Giants? I saw it a minute ago.
Yes, it's Jessica at mightyllittlegiants.org.
And, you know, we also want to give a shout out to the March of Dimes because they're important resources at their webpage, which is www.marchofdimes.org. And then there was a question about what was the blood test for screening to determine a propensity for preterm birth.
And so there's certain biomarkers for that will identify women who have a risk for preterm births. And so in the small study that happened, about 75 to 80% of women, it was accurate in predicting those who would have a preterm birth. And it's not on the market now because you come out with the research and then it goes through, you know, the FDA, as we know, we're talking about COVID and vaccines, but it goes through sort of what they call, you know, bench to market, but looking forward to it being available in the next few years.
Okay, any other questions? Because I think this is an important topic.
So this is Dr. Swilley. I couldn't put a question into the Q&A, and I just wanted to ask Dr. Gregory, in terms of, we know Black women or just women in general, in terms of fibroids, does that predispose to preterm delivery, and is that a significant problem for Black women?
So the short answer is no. Like, having fibroids doesn't necessarily impact the pregnancy. However, if you have a lot of fibroids, if they're bigger than 5 centimeters, because fibroids can grow in pregnancy. And so if they outgrow their blood supply, then they can cause an inflammatory reaction, and that will cause contractions. The other issue is if you've been treated for fibroids and had them excised, then we actually recommend delivery early. And so that can put you slightly at increased risk for preterm labor, although we still want you to wait till after 37 weeks. But as Claudia says, late preterm can still have some problems.
I did see one comment in the Q&A or the chat when someone asked a question about adverse childhood experiences and its effect, and I saw you responded, but one thing that also came to mind, that we know that 3 to 4 adverse childhood experiences in childhood predisposes to chronic disease later, the very things that we worry about in pregnancy: diabetes, cardiovascular disease, obesity, all have some, you know, origins perhaps in adverse childhood experiences. So it's important from that standpoint, but also for the mother who is stressed that the fetus is exposed, the brain of the fetus is exposed to stress hormones, cortisol, which may have long-term implications for brain development of the baby. So it all ties in still, adverse childhood experience.
It does, and we think it's all at the DNA level, right? So the more stressed you are, the more epigenetic changes happen. And so I just, to the extent that, we can get to church or stream church or whatever mindfulness exercises you can practice can mitigate some of that. And so, and that's, I think, is where the benefit of social support. I really appreciate the stories of everyone sharing. I think ABWP is an example of social support, that there's no way that I would be here, or it's specifically to the level of my accomplishment, had it not been for ABWP. And so I think that we have really underestimated the power of the community and spiritualism and sharing our experience. And that's a reflection of the fact that our society is getting more and more and more isolated. And so I just want to thank you guys for putting this together, and to just remember that not only is there a power in story, but there's a power in supporting each other.
And this is Sylvia. That I know we're down to almost to the top of the hour. I suppose most people are surprised that as a geriatrician that I have a passion about maternal outcome. My grandmother died in childbirth. I'm a preemie. I had preemies. So we know that you can't get to be a geriatric patient unless you survive childhood and pregnancy. So it is all connected. I think my goal as my term with ABWP winds down is for all of us to use the crisis of COVID to be much more deliberate and intentional about creating a community. So everybody got some folks you love, you can pick up and FaceTime or call, and do that after this call ends. And finally, voting matters. Voting matters, and I'm passionate about voting because, number one, the reason voting matters is why in the great state of California, Medicaid is available for people up to 131% of poverty, and in the Chitlin Belt in Mississippi, it's 40% of federal poverty. Voting matters because Medi-Cal is expanded to people after pregnancy. Voting matters because I could go on and on. I think people are getting the hint. Since we're a not-profit, I can't say but too much, but voting matters because it creates a lot of the policies that makes California a haven for better outcomes as opposed to the Chitlin Belt where my family is from. So, we're very close to voting. There are online resources to determine if you're eligible to vote, if you're registered. If you have spare time, get folks in the Chitlin Belt and red states to vote also, because this really is about your life and about the life of the community and the life in the future. So now that we've hit the top of the hour and I have exercise president's privilege with a lot of enthusiasm, I want to make sure that I haven't missed any other questions. We have one more session on maternal mortality, which will be coming in the month of October, and somebody can give me a brain refresher on what day it is.
October 24th. October 24th.
Correct, at 2, my favorite time of the day, 2 in the afternoon on a weekend. And so this will be on mental health. And I think there's a lot of mental health issues generically with this COVID thing. There's mental health issues around the stresses of being pregnant. And this is California is a state that is focused on screening for depression and anxiety, prenatal, postpartum. And we want to be able to, and we will have an excellent presentation in a month. So I hope all of y'all come support the charity benefits so we can have more folks that look like me in the community serving. That will be on the October 18th at 11 o'clock. That's also virtual. And then the following weekend, we will have our final CME on maternal issues so the people can have a good start. So let me make sure I did not forget any questions. I would also encourage people again to support our partners, Mighty Little Giants, the March of Dimes, and ABWP's charity benefit. Hope everybody has a great weekend, stay healthy, and call somebody and tell them you love them.
Thank you.
Bye-bye.
Bye-bye. Thank you.
Thank you, everyone.
Thank you.